Thank you very much, Shafi and Plamen and the Webit team for giving me this opportunity. So to jump right in, I'm a doctor. I graduated in 2002. I wanted to build rockets before and be the first doctor on Mars. That hasn't happened yet. So I kind of applied some of my innovating thinking. But what I'm going to talk to you about is my startup called ELU. We change names as startups, we pivot. And I saw a problem in my daily practice in medicine. And that problem was, as an anaesthetist or an intensive care doctor, I would get called to see patients when they were having a cardiac arrest, when they were so sick that the resuscitation team got called or they needed to go to intensive care. Almost every single time when I arrived, someone's jumping on the chest, we're intubated the patient, breathing for them, they'd show their chart to us, and it'd be like, why didn't you call me sooner? Why didn't you give them antibiotics yesterday? Why didn't you give them this drug that day? What was apparent to me wasn't apparent to some of my colleagues. And it doesn't mean I'm an amazing doctor and they're not. We just looked at it from a different lens. I am more used to looking at very sick people where their physiology is failing, and some of my colleagues are not. And rather than kind of just sit back and go, okay, someone else will solve it, we decided to try to solve the problem. And that problem is that of the deteriorating patient. This is massive. 600,000, this is UK statistics, 600,000 people die a year in the UK. 75,000 of those deaths are deemed amenable, i.e. medical treatment may have stopped it from happening. 75,000 people a year. But that's the tip of the iceberg, ladies and gentlemen. For every 3 patients that either die or have an adverse event, such as acute kidney injury, sepsis, or something else, 1 to 2 of them did not receive the best care they could have. This is every developed country in the world. Your relative or you go into a hospital and something doesn't work perfectly, it could have been better. So I decided to tackle it for and this is an example for one particular condition, acute kidney injury. If 100 people get admitted to hospital, 20 of them will develop acute kidney injury or will have it. And 20% of those patients, 10 to 20%, 20% of those patients will end up dying. And they stay longer as well. They don't just come into hospital and die on day 1. So they take up massive resources. So in a hospital that takes 100,000 patients a year, 2,200 patients will end up dying because of acute kidney injury, and they cost more money. So how did ELU and our staff decide to solve it? We want it to be invisible. We don't want to come in and replace everything, because that's not going to happen. Medicine has a culture going back all the way to Hippocrates. So we want it to be invisible, but make it easier for doctors to be doctors, nurses to be patients, and my personal pet peeve, managers to get out of the way. So we use something called blood results. Nothing fancy, no new test. How many people in the audience have had a blood test taken? Raise your hand. Most people. Now, when you have a blood test taken, there's a bracketed number next to it that says if that number, which you don't really understand, is within that bracketed number, you're fine. That's wrong. What Maria was saying earlier about challenging assumptions, that's a graph of normal blood results on hundreds of thousands of people. The y-axis is your risk of dying in hospital. So you come into a hospital with a sodium, which is the blue one, of 135, you've got a 4.5% chance of not leaving hospital alive. You come into a hospital with a sodium of 143, you've got a 2% chance. But that's normal. That's more than if you've smoked for 30 years of your life. So we took all of that data, about 1 billion of them, mashed it up, used an algorithmic trading platform, i.e. a platform that kind of buys and sells stocks and shares, but instead of feeding it stock prices, Twitter feeds, news, we feed it medical data in real time. Your blood results, the time you came into hospital, the time a doctor saw you, what your previous diagnosis was. You've just had a tablet now, feed that data in, which already exists, and we make a prediction for every single person. For acute kidney injury, but medicine's already been doing this, but very, very badly. For acute kidney injury, we can't afford to see every one of those 20% of people, 10 to 20% of people who get acute kidney injury. We don't have the resources. So we see the sickest of those patients. And the sickest of those patients are the 1 in 3 who might die. So an algorithm exists that says, okay, if you've got a 1 in 3 chance of dying with acute kidney injury, hit the alarm button. But that only captures 356 out of the 2,200 patients. That's the international gold standard right now. ELU, which works in the background, doesn't need anything new, captures 2,096 of those 2,200 patients. It can be deployed in any hospital in the world tomorrow. And all the doctor or nurse notices is they get to see the patients earlier of the ones who'll die. And you know what the beauty of this is people talk about a cultural problem in medicine, as in doctors don't want to listen to you, nurses don't want to listen to technologists. They don't, but they do want to do the best for their patient. So if I tell Shafi, this patient's going to die in 3 days, and he doesn't listen to me, that's fine, because in 3 days, if I'm right, he will have the biggest guilty conscience imaginable, more than any relatives of that patient, and next time he'll listen and try to figure out and understand why. So it can transform healthcare very, very quickly. What does that mean by identifying these people earlier? It means, let's get the financials out the way. We can save £1,000 per patient. We can reduce the length of stay in hospital. Every hospital is packed. There's a bed crisis. There's a staffing crisis. We can reduce the bed days. We can see 208, this is the England alone, we can see 280,000 more patients a year and save that many bed days, as well as almost £300 million just in one country. And in each particular hospital, an average size Western European hospital, 1,800 more patients could be saved. And at a cost of less than 5 to 6%. I mean, we did some rough calculations, and for every patient that we identified, it turned out that it cost us £42, which is the answer to life, the universe, and everything after. So maybe Douglas Adams did have some prescient insight. But we haven't just done it for acute kidney injury. We've done it for everyone dying in hospital, and we've got early warning scores. They're called different things in different countries. Outreach scores, patient at risk scores. The one in the NHS, which I'm biased is, I'd say, the gold standard in the world, captures 20% of the patients who die 24 hours before they die. So 4 out of 5 come as a surprise. ELU, again, working in the background automatically, no new tablets, no new tech, nothing else required apart from a service. So you point a data feed to the cloud, captures 75% within an hour of you arriving into hospital, and 90% if you end up staying a day, i.e. you're sicker. So where are we now? This is based on over 1 billion blood results. It's being trialed in over 3 hospitals as a proof of concept. Hell, Google DeepMind copied our entire thing, and their stream thing is based on this. But hey, imitation is the biggest form of flattery. But you need an inherent culture to understand. It's not just about technology. It's about people. It's about patients. And it's about how you communicate in a respectful manner, but also in a safe manner. We can't move fast and break things, because the things that you're breaking are people. So we are currently raising money, about 2 million. So if anyone wants to invest, come and chat to me later. We are also deploying clinical validation trials, starting off in the UK, but we're in discussions to do that in other European countries and in South America. So if you are a health system and you want to see if this works, come and chat to me. And you know what? If you want to learn more or just help, if there is a medical condition that you think this could help in, we want to help people. So come and give us a shout. And thank you again for this opportunity.